Chairman Schweikert, Ranking Member Hassan, and members of the committee, thank you for having me here today. My name is Matthew Fiedler. I'm a health economist and a senior fellow at the Brookings Institution. My testimony examines ways policymakers can reduce private insurance premiums. As a starting point, it's useful to understand where Americans' premium dollars go. In 2023, 90% of the dollars spent on private insurance were ultimately spent on healthcare, with 10% consumed by planned profits and administrative costs. Thus, while there are surely ways to squeeze profits and admin costs, substantially lowering premiums requires lowering underlying healthcare spending. And if the goal is to do that without removing high-cost people from coverage or shifting costs to enrollees via higher cost sharing or narrower benefits, that leaves two basic options: pay lower prices for care or use less of it. Let me start with prices. A fundamental challenge is that US healthcare markets are just not that competitive. In almost half of metro areas, patients have only one or two hospital systems to choose from. Physician markets are also often highly concentrated, in part because around half of physicians are now employed by hospitals. Limited competition allows providers to demand high prices. One strategy for lowering prices is to make markets more competitive. There are good ways to do that, such as increasing antitrust scrutiny of mergers or adopting site-neutral payments in Medicare to reduce incentives for hospitals to buy up physician practices. The Congressional Budget Office estimates that these and similar steps to boost competition might generate tens of billions of dollars a year in premium savings. While those savings are meaningful, it's important to recognize that they reflect price declines of only 1% to 3%. The modest size of those declines reflects the fact that even with these types of reforms, competition would often remain limited. Achieving larger price reductions would thus require different types of steps, such as capping the prices providers can collect or introducing a public option that sets prices administratively, as Medicare does. Let me turn next to utilization. Insurers invest considerable effort in rooting out wasteful utilization. In fact, they may sometimes be too aggressive in this regard and end up preventing access to necessary care. While it's clear that plenty of wasteful care is still delivered, this may largely reflect obstacles that are hard for policy to address, such as practical challenges in identifying what care is actually low value in real time. But there are avenues worth exploring. One is encouraging delivery of services that generate downstream cost savings, such as certain preventive services and curative therapies. Insurers may be too stingy in this domain because they expect some of the savings to accrue after an enrollee has switched to a different insurer. In practice, it may be hard to save a lot of money in this area since relatively few services appear to reduce costs on net after accounting for their upfront costs, but there are some exceptions, such as vaccines for children and treatment of hepatitis C, and there may still be opportunities to improve health at relatively low cost. Another option is continuing efforts to move Medicare away from fee-for-service payment, which may generate spillover utilization savings among the privately insured that private insurers could not achieve on their own. Before I close, I want to touch briefly on the looming expiration of the enhanced premium tax credits. If they expire, marketplace enrollees will pay around $1,000 more per year on average, and around 4 million people will become uninsured. Steps to reduce underlying insurance premiums, while valuable, are not a viable strategy to preventing those types of impacts. One issue is that they could not be implemented quickly enough, but the problem is more fundamental than that. Fully protecting enrollees from higher costs would require pre-subsidy premiums to fall to match the income-based amounts that marketplace enrollees pay under the enhanced credits. For the large majority of enrollees, this would require implausibly large premium reductions. Consider a 40-year-old with an income at twice the poverty line, or about $31,000, an income level that 65% of marketplace enrollees were at or below in 2025. With the enhanced credits in effect, this enrollee pays $626 per year for the benchmark plan. But the average benchmark premium for a 40-year-old is $7,500 a year. So to fully protect the enrollee from paying more, pre-subsidy premiums would need to fall by 92%, which is clearly unachievable. Importantly, the reason the required declines is so large is not that marketplace coverage is uniquely expensive. To the contrary, marketplace premiums are comparable to or somewhat lower than premiums in employer coverage. Rather, it's a reflection of the high cost of healthcare system-wide and policymakers' judgments about how much low and moderate income people should pay for their health insurance. To be clear, reducing underlying premiums would have many important benefits. It would reduce costs for people with employer coverage and reduce the federal cost of subsidizing both marketplace and employer coverage, savings that could even help offset the cost of extending the enhanced credits. But if policymakers want to shield marketplace enrollees from the cost increases they now face, reducing underlying premiums is not a viable strategy. Thank you again for the opportunity to testify, and I look forward to your questions.
Thank you, Mr. Chairman. I know that there's obviously, it's a hot topic around here, and it should, in the sense that Obamacare's been a disaster for working families. In Missouri, premiums are up over 200%. Insurance profits are up over 1,000%. Insurance companies are doing quite well, but working families have found it harder and harder to pay for premiums. Their coverage has become more scarce. And I want to address a couple things that maybe get at some actual policy solutions. So, Mr. Roy, right now, families can apply for coverage without verifying immigration status of the whole family. What fixes would you suggest that could close that loophole?
Senator, as you know, there was a recent GAO report that raised a lot of concerns about all sorts of program integrity in the AC exchanges. That report was specifically about, I think, income verification and ID and social security numbers, but same goes for immigration status, right? So if you have a robust system for program integrity where you're verifying people's social security numbers, that should address immigration status because those two things go together. But also what's really important is that one of the design flaws of the ACA is there's this kind of honor system where you're asked to estimate what your future monthly income is, and then you get a subsidy based on what you think your future monthly income is. It's very hard to then claw that back. There's technically provisions to do that in the law, but it would be much better for ACA subsidies to be based on your previous year's IRS returns rather than some honor system of what you think your future income would be.
What would be, I'm familiar with what the recent report you're referencing, where I think it was like a 97% fraud rate. If you were submitting a fictitious name or a social security number or the same name as somebody else, under the current system, what could be done to address? This seems like something that you could have broad consensus, I would hope, broad consensus to do.
I mean, in theory, these are the kinds of things that I would have hoped DOJ would have achieved, right? These are things executive branch, program integrity measures, CMS and HHS already have a program integrity division. It doesn't seem to me like it would be that hard. The one complexity is with the ACA is that there's a federal exchange that many states participate in, and then some states run their own exchange. And so maybe there would have to be a slightly different verification process for the states that run their own exchanges versus the federal one. But as an outsider, it seems to me this should be a pretty solvable problem.
Thank you. Or Dr. Clark, I should say. It's the healthcare, I mean, a third-party payer system is sort of ripe with, consumers are kind of removed, obviously, from a lot of the decision-making they would make when they're at a grocery store or making any other economic decision. But as it relates to hospitals who are still by and large paid for utilization as opposed to outcomes, what are some of the incentives that currently exist for maybe overutilization that Congress could address?
Thank you for the question. So speaking from EnerHealth's perspective on this, this is why we as a payvider, we own hospitals, we own medical groups, we own insurance plans. We want to take a risk on the overall population, so it takes those, what can be perceived as perverse incentives out of it, right? Years ago, a hospital might be paid more for heads and beds, right? Someone comes to the ER, care is rendered, they get admitted, there's a payment made there. If we're managing a population, and the pilot which we're proposing looks at this, having us be responsible for hitting a cost target for that population is where we want to go, because it doesn't. It's to our benefit to keep them from getting admitted. Especially for avoidable conditions such as heart failure, diabetes-related cost, CKD, things that we know upstream primary care and excellent specialty care can prevent. That's better health for the members and the patients, and since the payment is paid on the front end, that helps alleviate in levels of playing field, so we can work as a system to where we don't have to think about those things as much anymore.
I probably don't have time for one more question. Mr. Roy, because I do think that there's a lot of rhetoric on both sides, but trying to actually get to some solutions is important. Competition is obviously going to be a very important aspect of this, of lowering costs, so it'll matter for real people. In your view, why in Obamacare was there a prohibition for physician-owned hospitals? I don't understand that. Do you think that would be helpful? Why does that exist?
Because the American Hospital Association asked for it as a condition of their support for the bill. That's what happened. But the policy argument, the claimed policy argument, was that there would be a conflict of interest if there were physicians owning hospitals, that they would refer people to their own hospitals and therefore steer people away from other hospitals. But what in reality has happened with the ban of physician-owned hospitals is the opposite has occurred. The hospitals buy the physician practices and control the referral volume. So that was a terrible mistake, and I would argue it should be repealed.
Thank you. Thank you, Mr. Chairman.
Thank you, Senator. Madam Senator.
Well, thanks so much again for organizing this hearing. And to my colleagues, there is bipartisan interest in going after fraud. We know, for instance, in the ACA exchanges, there are brokers who are fraudulently enrolling ghost enrollees. And those are the types of thing, along with two-step authentication in some of the exchanges, which would be very basic things we could do to deal with some of the fraud issues. And also on the issue of physician-owned practices, hospitals or hospital-owned physician practices, there's a lot we can do on site neutrality and transparency so that people actually know what they're paying for. And we can crack down on some of the gaming that hospital systems are doing. So I would look forward to working with my colleagues on both sides of the aisle and in both chambers on that. I wanted to start with a question to Mr. Tingle. So first of all, a big thank you again for being here and for bringing your New Hampshire perspective to Congress. In your role leading a major United States life insurance provider, could you speak to us about the value of increased access to preventive and primary care for Americans and explain the incentive programs that your company uses to lower costs?
Great. Thank you for the question, Ranking Member Hassan. And it's my pleasure to talk about two things that I'm very passionate about: prevention and then early detection. It's funny, there's some purists around prevention that think, oh, good health is all about prevention.
Right.
And we all know bad things can happen even if you do all the right things. My wonderful mother never smoked a cigarette in her life, ended up getting lung cancer. So yes, prevention, but also early detection. Yeah. And there are, the wonderful thing about our society today is there are so many tools and technologies to help on all those things. Data to inform, am I getting enough sleep? Am I getting enough physical activity? Screenings that weren't available even just a few years ago. We offer our customers heavily discounted access to multi-cancer early detection tests. And I've had many customers find out they have stage 1 or 2 cancer versus 3 or 4. And we all know treating late-stage cancer is 8 or 9 times as costly as treating early-stage cancer. So we in our industry, at least we at John Hancock, view it as a great opportunity, but also somewhat of a responsibility to engage our customers, educate them about these tools and technologies that are available, make them easier to access. What does easier mean? Sometimes a discount, a reward. And then once they generate the data, I think the next frontier is how do we all harness this data to drive actionable insights? So my ring is telling me this, my watch is telling me this, my labs last week told me this. Now I talked to my doctor about what?
Yeah.